I'm Lee Swanstrom. I'm here doing author interviews for GIE. I'm very happy to do that, and very especially pleased to have Matt Bechtold here to discuss his work on ADR, adenoma detection rate, with deep sedation versus minimal sedation. So it's a pleasure to have you, and thanks so much for giving us this great paper.
Thanks for having me.
Yeah. So maybe you can give us kind of a quick summary of the setup of your study design and kind of what your hypothesis was when you first went into the study.
Absolutely. What we were looking at is the difference in the adenoma detection rate between using deep sedation with propofol and moderate sedation using fentanyl and midazolam. There's a lot of interest in whether propofol actually enhances your adenoma detection rate, so we did a retrospective study looking at it. And we had a unique perspective at our institution with our ambulatory care center where we do our endoscopies. We had a transition completely from moderate sedation all the way to deep sedation with propofol. So we looked at what we did before with the moderate sedation, and we gave a little washout period of about 6 months. Then we looked at afterwards how we did with deep sedation and compared the polyp detection rate and the adenoma detection rate.
Great. Before we get into the results, it was kind of an interesting shift. We actually went through the same thing in Portland, converting over to propofol sedation for all of our endoscopies. For old guys like me, it was a little bit of a mental workaround to do it. What was the decision-making factor on that?
That's a great point. I'm sure you found out too. It's an efficiency issue. With propofol, we were much faster getting them asleep, much faster waking them up. They woke up more in a euphoric state rather than a crampy pain state with moderate sedation, and we could get through more cases in any given day. And there's a lot of different ways we gave propofol, but we gave it with the cRNA in our institution.
And in the two arms, so they were temporal arms, so you had a period before you initiated this period afterwards. Your faculty was all the same during both periods?
That's a great point. The faculty was the same. The fellows switched because they want to graduate. You know, they want to go out and get a real job. So I think that we only had third-year fellows there, and the fellows that were there had over 500 colonoscopies apiece. But we did have a transition of fellows, but the faculty remained the same during the 2 periods.
So they're pretty comparable groups, all in all. Yeah. And the anesthesia, the deep sedation, was administered by cRNAs or by
cRNA that's supervised by a gastroenterologist.
Okay.
In both groups, we only do ASA 1s and 2s at our ambulatory care centers. So we really didn't count the real sick patients. We used mostly the healthy index screening colonoscopy folks.
Right. So why don't you give us a summary of what you found? I think it was almost 600 patients that you had in the 2 groups. Maybe you can tell us real quick if one is better. Maybe I'll back up. I asked you about the hypothesis. Your gut feeling when you went into this was that maybe the ADR would be higher in the propofol group?
That's what we thought. But then when we looked at it further, we found that there was no statistical difference in polyp detection rate or adenoma detection rate between those getting the moderate sedation and those getting the deep sedation. We found that adenoma detection rate was about 44% in those getting moderate sedation and about 38.5% in those getting deep sedation. So again, no statistically significant difference between the 2.
It's quite high ADR. It's a good metric for your group, I would say.
Well, thank you.
Yeah. So is there other reasons to consider propofol versus moderate sedation? Cost issues, or as you mentioned, throughput?
Yeah, there's arguments on both sides. The cost, the propofol is going to overall cost you more because you have to have a cRNA present or an anesthesiologist present helping you out, and that's going to drive up the cost. On the flip side, you know, patients do like having that feeling of not being awake through their procedure and waking up at the end. And sometimes you can't achieve that with moderate sedation because you have to be somewhat arousable. And they sometimes will wake up and remember some things. Also, post-procedure wise, patients that get propofol, as you know, seem to feel better than those who got the moderate sedation.
Right. Any issues with repositioning? Any of your faculty kind of repositioners, and was that a learning curve for them to have patients a little bit more asleep?
Yeah, sometimes. And the CRNAs at our place do a great job, and they help move in position. You know, they have to go to the back or on the right side. They do a great job. We limit that as much as we can, but it does happen, but they do a great job of doing it, and some of the faculty have to kind of, had to kind of get used to it.
Yeah. Have the results of this kind of influenced your in-hospital kind of more complex cases as well, or do you routinely in the hospital do propofol anyway?
In our hospital setting, we also do conscious sedation, moderate sedation, and propofol. I think that for our sicker patients, those that are ASA 3 and 4, we really, based on our guidelines of our hospital, have a CRNA and anesthesiologist present, so we use most of those under deep sedation.
Mm-hmm. And considering you said added cost to it and no significant difference in clinical outcomes, you're going to continue doing it because the patients liked it?
For now, for 2 reasons. One, the patients like it for patient satisfaction, but also, like you said, for the throughput, the efficiency,
Mm-hmm.
getting more cases done per day, able to take care of more patients in a given amount of time is really helpful.
Okay, that's great. Well, again, congratulations, and thanks so much for bringing that paper to us and publishing in GIE. I'm always happy to have excellent work like that.
Great. Thank you for having me.
Matt. Yeah.